Hello, hello. Good morning. Good morning, guests. Thank you for joining our presentation today. This is Terry Torres, and we're going to start the webinar in just a few moments, giving time for all of the interested parties to arrive. So, we appreciate your patience, and we'll get started here in just a moment. Thank you. Okay, guests, thank you again for joining. This is Terry Torres. I am the area manager for senior lifestyle with sales and marketing. And today, the Gardens Group, which includes Fullerton Gardens, Sunflower Gardens, and Valley View Gardens, has partnered to bring you a really special guest today. Our Gardens Group is a standalone memory care trio servicing all of Orange County. And specializing in providing solutions for those in need that have memory impairment, right? So those that are journeying on with dementia and helping to support not only the senior but their family and loved ones as well. And through our experience, we've been able to partner with Dr. Tehrani, Dr. Michael Tehrani, who is the CEO and founder of Medwell Medical. And his purpose is all about keeping seniors medically well. And I can certainly attest to his services in being such a brilliant professional partner, providing us with mobile services where he comes into our communities, very attentive, excellent bedside manner, and a true geriatric specialist and dementia care professional. So we're excited about this presentation. We wanted to bring you some information about dementia from a very practical standpoint and be able to provide you some tips on how to manage the disease process and behaviors at home. So without further ado, Dr. Tehrani, if you're ready, take it away.
Good morning, and thank you for the kind words. Give me 1 second. I'm logging in. Give me 1 second.
Okay.
Okay, good morning, everyone, and thank you for joining us during this hard time of COVID. Can you hear me okay?
Yes.
Okay, great. Thank you. It's been very hard on COVID. with COVID, in many aspects, and some aspects of it are not on the news and we don't hear about it a lot, but it's very important, particularly with the with memory care patients or dementia patients, where it's difficult to explain to them what is going on, why you can't go out as much as you used to, or why family can't come visit you, especially when there's short-term memory loss and you keep it keeps getting forgotten as to why you can't go out. It's been very challenging and difficult to try to stay with patients, not stay with patients, but it's been difficult to try to explain to patients the importance of staying home and why we are staying home. And this is one of the reasons why I wanted to have this conversation about dementia and how to cope with it in general, but especially now when it comes to COVID-19. I want to say a special thank you to the Gardens group for working with patients with memory. I look at the Gardens group like I do, for example, you look at In-N-Out, for example, they're good at burgers and burgers only, and then that's what their specialty is. And Gardens group is similar in a sense that they understand dementia patients because that's all they work with is dementia patients. And so I'm very honored and privileged to work in their buildings with them, and I really enjoy working with them in their buildings. And I see how well they understand memory patients. And as we go through the next slides, you will see, we will talk about how with memory patients, it's very different, and how to work with them, and the behavioral aspects we use to work with them is unique and specialized. And I like to think that with memory care patients, it's very difficult because we do a lot of the don'ts and we don't do a lot of the things we should be doing because just of the nature of dementia. So as we go through the next slides, we'll define what is dementia and how patients present and what they're thinking when they present that way, and what is the best solution to cope with that, or to work with that behavior to get the best outcome. Next slide, please. Okay, there we go. So before I get to the next slide, I just wanted to tell you a little bit about myself. I'm Dr. Tehrani. People often call me Dr. T because it's easier. Some people still have a hard time remembering Dr. T, so I just kind of give them a little easier way to remember it. I tell them you can call me Sweet Tea if you like, and with that they usually remember my name, which is nice. So I'm an internal medicine doctor that specializes in geriatrics. And what is geriatrics? I often say it is the opposite of pediatrics. So we take care of older adults, and older adults is usually defined age 65 and over. So around the age of Medicare age is usually the age where we start taking care of older adults. How is it different than middle-aged adults? It's the same way where pediatrics is different than internal medicine, whereas the pediatrician knows everything there is to know about kids and knows how medications interact with their bodies, and usually takes care of, it's a one-stop shop where the pediatrics takes care of everything. It's the same thing when it comes to, let me just turn this phone off. It's the same way when it comes to geriatrics. Geriatric doctors usually, they take care of most everything because we understand how hard it is to go from appointment to appointment. So most geriatricians, they they're able to handle a lot of the care themselves, again, because we know how hard it is to get to all these different specialty appointments. So a lot of times during my visits, instead of sending patients to the subspecialist, I'll just get on the phone with the subspecialist and review the case and see if they can assist me without the patient having to go there. Particularly in this COVID time, we do a lot of telemedicine with the subspecialists, and we help coordinate. That. Other things that's important when it comes to older adults is to review all medications all the time. You want to make sure that there is no medication interactions, that when you do see a subspecialist and they do start a medication, that the benefits outweigh the risks when it comes to your body and when it comes to other medications that you're on. Geriatric physicians are also available around the clock most of the time, because in older adults, something relatively small will rapidly progress to something big pretty fast. And infections don't believe in holidays or weekends or after hours. They just keep replicating and dividing and getting worse. So our group, we're available 24/7 so that we can prevent something small becoming something big just because there was no interventions made. So we are available. Geriatrics in general are available around the clock to catch things early so that you can still treat it with oral antibiotics, and that it doesn't have to lead to a hospitalization or treated with where IV antibiotics are the only things that are going to help. Working with a building as the gardens, it's very helpful because you work as a team. They are the doctor's eyes and ears, and they work with our telemedicine platform, which makes things happen really fast. When the facility calls us and we can do telemedicine, they can check vitals for us. In times like that, you can initiate treatment within minutes instead of having a doctor or a nurse go out to the facility to assess. All that takes 4 to 5 hours time at best. And that 5 hours is 5 hours where the infection is replicating. And each time it replicates, it doubles. So you go from 1 to 2 or 500 to 1,000 within minutes or seconds. And the quicker you can stop that replication by intervening, the better. And nothing is faster than having a team that's there already, who knows the patient, works with the doctor, gives the doctor a sign out. We give the facility the tools to be able to give us the appropriate sign out, and we initiate treatment right away. So those are really important tools to have as a geriatrics doctor, to have as a team with them, with the facility, so that we could initiate care as fast as possible. Okay, with that said, let's get into dementia. The first slide is what causes dementia? Well, a lot of people, they feel dementia is Alzheimer's and they're equivalent. Dementia, all dementia is what I think we went one slide too ahead. Can we go one slide back? Where it says dementia definition. I think it's one slide. No, we're going forward. Let's go back. There we go. Perfect. Dementia definition. So the definition of dementia is anything. So the brain has many functions. Any part of the brain that gets affected, it can lead to dementia. So dementia is an overall term for disease in which one's cognitive ability of everyday activities has been compromised by changes. So the brain has been compromised. The brain's cognitive ability has been compromised. So what is the, so we're saying the brain's cognitive ability has been compromised. That means, so what is the definition of cognitive? Cognitive means anything that involves thinking, processing, memory, behaving, judging, managing emotions, language, deciding, seeing. These are all considered cognitive. And if any one of these are affected or compromised, the definition is dementia. So by compromise, we mean affected. Also, this change, this cognitive this compromised cognition, it has to be irreversible. That means it has to be permanent. So if you have permanent cognitive compromise, that means it is considered dementia. There are more than 70 different types of dementia because there are more than 70 different parts in our brain that function in thinking, processing, memory, behaving, judging, etc. that can happen. Memory is just one of them. So if the memory part of your brain is compromised, that's called Alzheimer's dementia. If the part of your brain that's affected is the part that involves judging, then that's called a different type of dementia. And we'll get into that. And we'll get into the four most common types of dementia. And remember, dementia is not reversible. If it is reversed, it is called pseudo-dementia. Pseudo means fake or mimics dementia. What can you expect to see on a brain MRI or a brain imaging? It's like a muscle. The brain is a muscle. So let's say you're not let's say you're not using your leg muscles, then your leg muscles start to get small. If you're not using your bicep muscles, then your bicep muscles begin to get small. It's the same thing. If the part of your brain is not working anymore, then that part of the brain begins to get small. And that's what you begin to see on brain imaging. So there is that saying, use it or lose it. And again, if you're not able to use that part of the brain anymore because that part of the brain died, then it begins to shrink, or the medical term for it is atrophy, and you begin to see those shrinkages on brain imaging. What causes dementia? For every different type of dementia, it's a little bit different, and we'll get into what causes, why suddenly does a part of the brain get compromised, and we'll get into that. Okay, the next slide is, sorry, one second. So let's go back to where it says what causes dementia. Perfect. Okay, so what causes those brain cells to become compromised? Well, we don't know. We don't know exactly. What we know is those brain cells, those neurons, some kind of protein gets sometimes deposited inside the cell or outside of the cell, and it stops it from functioning. Imagine you have a room and someone just pours water or cement in the room, and now you can no longer use that room. It's just like that. The neuron or the brain cell proteins get spilled into the cell, and the cell can no longer function. That room, that cell becomes non-functional anymore. And the way the brain works is, it's kind of like a lot of people holding hands, and one person passes something to the next person, and that person passes it to the next, to the next, to the next. But if one of the people is now non-functional, then the transmission of information stops there. It's like a Christmas tree. If you affect something proximal, all the lights distal to it are going to be affected. So that's how it works. So one of the brain cells or a clump of brain cells, they stop functioning because proteins or something gets spilled into it, and now that cell can no longer function. Okay, let's go to the next slide. Okay, perfect. Types of dementia. Some dementias lead to major behavioral problems, and some type it leads to major physical problems. So did the dementia, depending on what part of the brain the dementia affects, you can have people with dementia that they have a lot of mental problems, or there are some dementias that it's much more of a physical problem. So let's look at the two extremes. Let's look at the types of dementia. So on the vertical graph, on the vertical bar, we have dependent versus independent. That means how dependent physically is the patient and how independent they are physically. And then on the bottom, the horizontal bar is mental versus physical. So Alzheimer's, these patients have a lot of mental dependence because it's mainly a memory problem. They can still walk, and in fact, they walk a lot, hence why patients with Alzheimer's, they often get lost. Or they can get lost because their walking ability, their physical ability is intact, but their mental ability is compromised. Whereas on the other end of the spectrum, you see someone with Parkinson's disease dementia, they are very physically compromised, but mentally they are still relatively more independent. And what is Parkinson's? These are patients that have much more of a lot more rigidity, a lot more of a tremor problem, but mentally they're less compromised. So like when you see like Michael J. Fox, for example, he has a lot of physical compromise, but his memory and his mentation is still relatively better. Whereas someone with advanced Alzheimer's, they can still walk and they can still walk. They don't have any problems with shakes or rigidity or tremors, but their memory is very affected. Okay, let's go to the next one called pseudodementia. Okay, pseudodementia. The key factor here is that it's reversible. So there are times where things can affect your brain or temporarily compromise your brain, and it mimics a dementia. So we've heard about patients that they have an infection and suddenly they're not with it, but the moment you treat them, they get better. So infections can lead to dementia-like behaviors, hence pseudodementia. Medications or delirium. Now, infections, it's pretty clear. Sometimes the body clears the infection itself and the patient gets better, or you give them an antibiotic and they get better. But one of the more hidden ones is medications. Remember, medications have side effects. So if you're on the wrong medication, or you're on the right medication but the wrong dosage, or you were on the same medication but now the dosage is too high for you, because as we age, things slow down. So if your body is not able to break down the medicine like it used to back when 20 years ago, now the medication is lasting in your body a lot longer, hence why it has much more of a side effect on you. So medications, if they're the wrong meds or the wrong dosage, or there's an interaction with other meds, medications can cause patients to have memory or cognitive compromise, and they too will present like memory like problems. And the sad and the unfortunate part is, if that medication is not changed or adjusted, a person that can potentially be back to normal is not going to be back to normal until you withdraw that medication or withdraw the thing that's causing problems. Delirium is if the patient doesn't sleep for 3 to 4 days because they can't sleep at night, or for one reason or another, you become delirious if you can't sleep. Let's say they're on the wrong medications and they're coughing all night, or one reason or another, they're in the hospital And you know, in the hospital, they check your blood pressure every 2 hours. Someone keeps, and if you don't sleep, you start becoming delirious. So these are the three main causes of reversible dementia. Again, infections can be is more obvious because the patient has fever or chills or something else. Delirium is a little bit more obvious, but medications is one of those hidden things that suddenly you'll take off a medicine and then suddenly the patient will have a lot more clarity. Because remember, dementia is the patient is not clear anymore. There are medications that take away patients' clarity. Okay, let's go to the next slide, please, where it says Alzheimer's dementia. So we're going to talk about the four most common types of, we're going to talk about the four most common types of dementia. And number one type is Alzheimer's. Again, remember, dementia is just an umbrella term that talks about all the different types of dementia, and Alzheimer's is just one type. It's like me saying the word vehicle. Under the word vehicle, you can have trucks, you can have cars, you can have pickups, you can have convertibles, you can have Honda, Toyota, all these different types of cars, but as a category, they're considered a vehicle. And a Honda is a type of vehicle. So is a Toyota, is a type of vehicle. Same thing, dementia is just an umbrella term, and Alzheimer's dementia is just a type of dementia. What kind of type is it? It's a type that affects the hippocampus of the brain. What is the hippocampus involved in? Hippocampus is involved in memory formation and memory retention. So if you affect the part of your brain that deals with memory formation and memory retention, then you can no longer build new memories, hence why your short-term memory begins to get depleted. And as you're not, and then it starts to affect your longer-term memory. And what happens is your newest memory starts getting taken away from newest to oldest. So let's say you're a person who's 95 years old and you start having Alzheimer's dementia. You start forgetting where you put your keys, you start forgetting what you had for breakfast, you start forgetting these short-term things. You start forgetting what you did at the age of 94, then 93, then 92, and as it advances, your age goes up, but your memory age goes down. So let's, 95 was not the best age, but let's use someone who's about maybe 80 years old. As this person becomes 85 years old, their memory then regresses to when they were 60 years old, for example. And they forget everything that happened from the age of 60 to 85. So hence why when you ask them who is the president, they will tell you who is the president when they were 60 years old and not when they were 85 years old. So as, let's say the patient is 86 now and their memory is now when they were 55 years old. Or let's backtrack a moment, and let's say this man lost his wife at the age of 70 years old. He's 86 now, his memory is at when he was 60. He'll start talking about his wife. And where is my wife? Because at the age of 60, his wife was there. He's forgetting that his wife passed away. Then as his dementia progresses and he's 90 years old and his mind is at the age of 30, for example, at the age of 30, he didn't have kids. So now he forgets that he has children. He looks at his children and he has no idea who they are. He starts talking about his wedding day, because that's when at the age of 30 was when he got married. So he starts talking about his married days. As it continues to advance and advance and advance, and in severe cases, they're at the age of 5 years old mentally. What do 5-year-olds do? They start playing, 5-year-olds play with other 5-year-olds. They start coloring books. This is not a pedophile of a person. This is a person who mentally he's at the age of 5 years old, and 5-year-olds do what other 5-year-olds do, and that's play with each other, color with books. So sometimes I have heard things like, wow, I never knew father was like that. But it's not that father is like that. It's just that the dementia is advancing. And he's at that age level of a 5-year-old. Now, the hippocampus cells, proteins get developed, get spilled into it, and we don't know why that happens, but if we but it does. It's part of dementia. And again, there's a lot about dementia we still don't know, and we're learning day to day. So with patients with Alzheimer's dementia, instead of trying to teach them what to do, remember, the common thing is the logical thing in our mind is, let me teach father what to do. It's not, but we have to remember, we can't teach them. Trying to teach them is like trying to say, I'm going to teach a fish how to climb a tree. They've lost that ability. The same way the fish does not have an ability to climb a tree, the person with Alzheimer's has lost that ability to learn. So instead of teaching it to them, you're not going to succeed. You're going to frustrate yourself. You're going to frustrate your loved one, and it's not going to get anywhere. So this is one of the common things where we think logically, okay, let me teach them, but it's not going to work because they've lost that ability to learn. Instead, we need to do it for them. So let me give you an example of this. The reason why we're spending a little bit of time with Alzheimer's dementia, because it's one of the most common types of dementia. So in early Alzheimer's, where a person begins to lose their short-term memory, is usually when I have like a mom come in with a mom and a dad come in with their daughter, and the daughter says, Dr. Tehrani, and I tell the daughter, moving forward, let's cut in half your father's medication. And let's say the father has dementia and the mother is fine, but she's beginning to show early signs of dementia. We say to the daughter and to the mom, moving forward, cut your dad's pill in half and give him half this pill instead of the full pill. And the mom says, okay, I will do. And the daughter and the mom and the dad, they all go home, and the daughter checks on the mom in a few days, and she notices that the mom is still giving the dad the full pill instead of the new half a pill that we recommended. And she gets upset with the mom and says, Mom, I told you, please give him half the pill. How come you're giving him the full pill? And the mom says, I'm sorry, I forgot, or I did not mean to. I will give him half a pill moving forward. Come back next week again. The daughter checks on mom and dad, and she sees the mom is still giving the full tablet instead of half the tablet. And the daughter starts getting upset with the mom and frustrated with the mom and says, Mom, I told you, give half a tablet. Why do you keep giving a full tablet? Are you trying to hurt Dad? Why do you keep giving him the full tablet? And the mom again, tries to cover it up and says, I'm sorry, I did not, I made a mistake. I will give the full tab. I will give the half tab moving forward. This frustration, the mom is not doing this on purpose. The mom cannot remember this new thing we're telling her to remember. This is the beginning signs or the early signs of dementia. Patients are very bright and they are going to try to cover it up. But the ultimate thing is they can't cover it up, and getting upset with mom or trying to teach her to do it right is not going to work. And these are times where you have to begin looking into a caregiver. You remember, you have to do it for them, not try to teach them. And you can either do it for them by hiring caregivers or moving into a facility or into a long-term residential care with 24-hour care that can do it for them. But someone needs to do it for them instead of teaching them to do it. So that's Alzheimer's dementia. Next one is vascular dementia, also known as multi-infarct dementia. This one is when you have tiny little strokes around the brain. Not one big stroke, but tiny little strokes here and there around the brain. Part of aging, it happens. It happens if you have cholesterol, diabetes, hypertension. And little strokes happen. And when a lot of little strokes happen, it can lead to a clinical symptom. Usually the hallmark symptom of vascular dementia or multi-infarct dementia is emotional lability. What that means is the patient cannot control their emotions. So let's give an example. Mom, it's morning time and let's have breakfast. Mom says, no, I don't want to have breakfast. Go away. I don't want to have breakfast. Leave me alone. I don't want to have breakfast. But Mom, it's 12 o'clock. You haven't had breakfast all day. But no, I don't want breakfast. Leave me alone. Go away. Or Mom, it's Sunday. We go to church every Sunday. Let's go to church. And Mom says, no, go away. I don't want to go to church. Leave me alone. Now, what are we going to do as caregivers? Our role is to try to convince Mom to eat, because Mom, it's healthy for you to eat. If you don't eat, Mom, you're going to get thinner. You're going to get weak. We are going to try to logic with them to try to eat. We're going to logic with them as to why it's good to go to church. On Sunday, you've been going and you haven't missed a single Sunday in all these years, and your friends are there to see you, etc., etc. Trying to logic with them is not going to work, because they've lost that logical part of their mind. It's the best analogy I can think of here is if you think about your computer and your computer just freezes. You can sit there and hit Control-Alt-Delete or run the keyboard and try to make it work again. Or you can do what most of us do, unplug it, wait a minute, replug it, and that seems to always solve the problem. It's the same thing when it comes to vascular dementia. You have to let the patient reset. So the common thing we're going to do is try to convince them, but the right thing to do is to step away for a few minutes, let them reset, and come back and tell them again, Mom, let's have breakfast. And more than likely, they're going to say, okay. It's as if they completely forgot the whole conversation 5 minutes ago. So that is the hallmark symptom, is this emotional lability. The treatment for it is don't try to convince. Instead, let them reset and step away, come back in a few minutes, start the conversation all over again as if you never had that conversation to begin with a few minutes ago. Now, again, I'm being very black and white here. There are going to be times where these things won't work. Most of the time it should work, but again, it's not as black and white as I'm making it. But if we understand the concept behind it and we try it, more often than not, it's going to work. But it's not 100% treatment that it'll work. But these are things that we can try, and they can work. And me with my patients, and I carry a very large load of patients with memory impairment, and I can vouch for it that these things work. And what I'm teaching here is not just what it says in the books, but what I've learned by working with caregivers that have taken care of patients with dementia for many years. And I ask them, teach me something. How have you learned to do this? It's just like working with kids. There's no kids that come with a manual. It's just talking to your friends who have kids and saying, hey, how do you deal with this behavior, with that behavior? It's the same way. I just learned from experience. I've learned from talking to people and caregivers, and I'm sharing with you all the things I've learned and I've tried and I've worked. Let's see what else on this part. So nothing more on vascular dementia. Let's go to the next one. It's called dementia with Lewy bodies. and dementia with Lewy bodies, these patients, their memory is pretty good, but they hallucinate. They see. What is the definition of hallucination? It's seeing things that are not there. Delusions, it's believing something that is not there, but you believe it. You believe it. If I tell you you're looking, you in your mind, you are looking at a screen that says dementia with Lewy bodies. If anyone was to tell you otherwise, you would tell them that's not true, you're wrong, I'm right, because you believe what you're seeing. Same thing with when someone hallucinates. What they see, they perceive that it's there. And if you tell them it's not there or try to convince them that it's not there, you're wrong, they are right. You're not going to get anywhere because, again, it's me trying to convince you that you're not looking at a slide with dementia with Lewy bodies, and you are going to believe what you want to believe regardless of what I say. So I can't try to convince you that you're not looking at that, because in your mind, you are and you believe it. So if mom, now most of the time what they hallucinate things is they see adults, kids, or pets or animals. Those are the most common hallucination things that they see. So sometimes you'll hear that the mom will say, the kid from the tree, the kid from the tree is falling, and she's sitting in a room and she's seeing a tree in her room, and there's a kid that's falling from the tree. That would make any of us anxious and nervous and anxious. Instead of trying to tell mom that mom, what are you talking, or dad, what are you talking about? There is no tree in the room. There is no kid falling, which is going to be the more logical thing that we're going to do. Instead of doing that, the answer is, because again, we have to go on their terms, on their beliefs. We have to say, Mom, let me go out, let me go catch the kid from the falling tree and make sure I protect it. That is the answer to it. Or if the dog is running at them, Mom, instead of Mom, there is no dog, or Dad, there is no dog, it's Dad, let me go get the dog and protect and put the dog out so that you're protected. This is the answer to it, instead of trying to convince them it doesn't exist. Sometimes they're walking, and then they pretend they're falling. They trip, they pretend they trip, or they fall. And then they say, you stuck your leg out and tried to trip me. And you're saying, I am in the other room. What are you talking about? I'm not even where you are. How can I stick my foot out and trip you? My foot is not that long. But again, in their mind, they hallucinated a foot was in their way, and it was your foot, and they tried to jump over the foot or whatnot, and they fell. And remember, part of it is paranoia. You tried to hurt them by sticking your leg out. And it may even lead to them calling the cops because you tried to hurt them. And the cops will come out and say, did you try to hurt this lady, your mom? And you're going to say, not at all. And they'll even ask your mom, Mom, what did you have for breakfast? And her memory will be intact. But remember, what part of her mind is affected is hallucinations. Now, again, there's going to be a lot of overlap. Most patients that have hallucinations are also going to have some form of memory impairment, because the brain is not delineated perfectly as to say, I'm only going to affect the hallucination part or the visual part. Although it affects one area the most, you also affect your neighboring facilities. It's kind of like a neighborhood. If something happens to one home, the neighboring areas are going to have a little bit of an effect of it also. And if the brain is very tightly condensed and packed, so if one area is affected, the surrounding area is going to get affected as well. Not as severely usually, but there will be some effects. So what I'm doing is I'm giving you very black and white explanations, but in reality, there is overlap as well. So dementia with Lewy bodies, instead of telling them or convincing them that something is not there, work with them and make them feel safe and secure. Next slide. Frontotemporal dementia. In this kind of dementia, what's affected is behavior and judgment. These are the areas where they'll just stand in public and urinate, because you and I, we know that's wrong. We have that filter that tells us we can't do this because it's not appropriate, but they don't have that. They've lost the ability to make yes and or right and wrong judgments. So when you lose that, you say things that you would not want to say. You do things that you would not want to do. That's otherwise embarrassing. Sometimes it's sexual behaviors. Sometimes it's loss of interest. Sometimes it's encroaching into your personal space, because again, they don't know that it's wrong. They've lost that devil and angel. You know, we have that devil and angel where we're constantly deciding and between what's right and what's wrong, and we don't say what's wrong. It's the same thing. They've lost that ability to be able to decide. Sometimes in memory care units, you see patients, they steal their roommate's blanket because they like it, because now it's theirs. They've lost that ability to say, this is not mine, this is stealing. They don't mean to steal. They just have lost the ability for judgment. So instead of trying to teach them that this is not your mom, or you're stealing, or dad, you're stealing, it's more you have to help and guide them instead of punishing them, or instead of telling them it's wrong. They don't know what's right and wrong, and they don't mean to do it to hurt anyone. It's just that they've lost that ability. Always remember, when someone loses an ability that they had, it's just like being a fish being able to climb. Again, always have that image in your mind that I'm asking a fish to climb a tree. You've lost that. If you've lost that ability, or if you don't have that ability anymore, then you don't have it, and you can't expect someone to do it. Let's go to the next one, rare forms of dementia. Again, we talked about earlier, there's over 70 types, and more than 70, and we just don't have enough time to go through all the different kinds. But we have Parkinson's, Huntington's disease, traumatic brain injury, Wernicke-Korsakoff, and hopefully at a future time we can go into more of these other rarer forms of dementia. I get at this slide, I get a lot of questions about, is dementia, is it inherited? My dad had, my mom has dementia. Does that mean I'm going to get it? Oftentimes, we take care of a lot of patients in the buildings, in community livings, and a lot of their kids come to us in our clinics in Orange County or Long Beach. And one of their main concerns, as they see their parents that have dementia progress, they get scared, and they often ask us, is this what's going to happen to me? Is this what I should anticipate? And the reality of it is most of the common types of the dementias are just sporadic, and they're not inherited. There are some rare types of dementia that are, but I think 99% of the dementias that are most common out there are not inherited. Again, there are some rare forms, but I think that's less than 1%. So it's not that common. So chances are it's not genetics. Okay, let's go to the next slides. We'll go through seeking help from specialized medical professionals. So here is where you saw that there is no turnkey solution for dementia. Every dementia presents differently. Alzheimer's, you treat differently than you do Lewy bodies. You treat differently than you do frontotemporal. You do differently than vascular dementia. You do so. It's not about my mom has dementia. What do I, how do I treat dementia? It's my mom or dad has this kind of dementia. How do I cope with it? Medications across the board, it's the same thing. It's usually donepezil and memantine most of the time. If it's, Parkinson's, it's Sinemet. There is no, you could say for medication, it's the same medicine across the board. And when you see your neurologist and, continue same meds, I think it's also important to ask them, to talk to them about the behavioral challenges you're having and how you can cope with these behavioral challenges, or how can you deal with these behavioral challenges, behavior modifications. If all else fails, sometimes you do have to go to medications, and there are times where we have to use medications, and medications, it works. One of my own private patients, married for 50 years with husband and wife, and the husband is developing dementia, where he's becoming very judgmental, and the wife says for the past 49 years he's been so good to me and what a sweetheart, but now he just picks at everything. We took 1 minute too long, and we tried every behavioral technique, and to the point where they were going to get separated. But we started medications for her and for him, and he's improved so much. It's almost back to normal for them, and they have a quality of life again. So sometimes you do have to go to medications, and as a physician, again, there's not that many mood stabilizing medications, but there are some that we've learned to use. And again, we work in conjunction with facilities very closely, such as the Gardens, who report back to us when we start a medicine. They remember, it's always the rule of thumb is start low and go slow. So we have this good relationship where when you start medications, they constantly report back to you, and we have to be very responsive back and say, okay, good, let's turn it up a notch, or let's turn it down a notch, or let's change the frequency until you hit the best you can. Medications are sedatives. They calm you down. So you don't want someone to be over sedated, under sedated. You have to adjust the medication in case they get a urinary tract infection, because then they're sedated from the urinary tract infection. So then you got to back off the medications. So that's where you have to have a very responsive group to work as a team together to report back and say, hey, this was, this is the behavior now, so we need to make adjustments. So it's important to have a strong team and someone who understands memory patients, so that they can report back the information, and then we can make adjustments accordingly. Next slide, coordination between your PCP and specialist. Remember, when you're working with your PCP, the rule of thumb is rule out pseudo-dementia. So first, when someone is diagnosed with dementia, or you're suspecting memory impairment, rule out those reversible causes. Common things being common, it's probably due to a medication change, or infection, or delirium. Ask yourself, has there been any recent medications added or subtracted or dose changed? Rule these out, and once pseudo-dementia is ruled out, then you can call it dementia. Remember, some foods, if you're lacking vitamin B12, it can lead to certain types of memory impairment. So making sure that you rule out all the reversible causes is important. Next slide. The importance of structure and routine. So importance of structure and routine. This is important because patients, remember, they cannot formulate new memories. So the more you can keep things as structured as possible, the more comfortable they will be. Patients, particularly in the early stages of dementia, they get frustrated a lot because they can't remember, and it gets very frustrating. It gets very frustrating when you go to where you knew things and you were very sharp and now you can't remember things, new things. So trying to keep things as structured and routine as possible helps patients with memory impairment a lot. Provide a sense of comfort and control. A person with early stages of dementia knows what's there. They're aware that they're beginning to lose their memory in the very early stages. You want to stimulate their mind. You want them to be as in control as possible because they've been in control all their life, and to take that control away from them makes them very uneasy and uncomfortable. So you want to give them sense of control, sense of comfort. For example, if you're changing the shirt of a patient with dementia and you're a caregiver, instead of just trying to change the shirt, and if they're not cooperating with you and they're not putting their arms up, you have to give them control. So you have to say, okay, mom, when you're ready, you put your arms up so I can take the shirt off. That will work a lot better than, mom, put your hands up, I'm going to take off your shirt. You have to let them be in control. Mom, turn over so that I can change the pads underneath you. When you're ready, let's do it. Give them sense of control. Let them be in charge so that they feel that they are still in charge. Okay, next slide. Preparing for the future and disease progression. Unfortunately, dementia progresses. If someone needs to do for them what they can no longer do, and if as a caregiver you can do it, great, but it's a full-time job. You already have your own full-time job. You already have your own family and kids. So there does lead a time where you caregivers get burnt out because you're literally living 3 lives now. You're living your own, well, you're living 2 lives. You're living the life of your mom or dad with dementia, and you're living your own life and all your own stresses. So I've seen it. It's not uncommon. You go to work, you're short with your staff members, whereas things didn't frustrate you. Now the smallest things frustrate. So it starts affecting your personal life. It starts affecting your life with your kids, with your husband, because something else in your life has taken so much out of you. You feel you're obligated to do these things because your mom took care of you, so you're obligated to take care of them. So you put all the pressure on yourself, but you can't do it alone. It does lead to caregiver burnouts. Sadly, unfortunately, I have seen caregivers die before the person they gave care for because of caregiver burnout. So you have to be, if it's beginning to affect your own life, you need to ask for outside help and outside placement so that someone else does the day-to-day care for you. It's sometimes some of us have a guilty conscience when we want to place our mom into assisted living. It's not a bad place. The right fit is the right place, and it would help mom a lot more than not. So if you don't know, it's tough to know. I didn't know what's out there before I went out there. For example, activities around the clock. If you have a 24-hour caregiver at home, yeah, maybe they can do activities at home, but you don't have that stimulation with other people. Maybe the facility has a pet and your parents have been raised with pets or love pets, but they can't take care of a pet anymore. Maybe if the facility has a pet, what better than having the pet there when you need it, and then it goes away when you don't feel like, or you don't feel like dealing with it. Food, cleaning, physician around the clock availability. Also, when I've seen, remember, we said in older adults, something small becomes something big in a matter of time. If you're home alone and something happens to you, and no one catches it for the next 6-7 hours, things have progressed. In a 24-hour facility, people catch these things early and they report back to the doctor, and there's interventions being made. So sometimes we see patients found on the floor for 8 hours, 9 hours until someone finds them or until family comes home. It's very sad and it's very unfortunate, but if these things begin to happen, these are the times when you need to begin to seek outside help or placement. And that's it. And the next slide is, some funny little cartoons, but outside of that, and that's all. Thank you so much, everyone.
Thank you so much, Dr. Tehrani. Thank you for being here and providing us with so much great information and resources. And if you all are interested in connecting with Dr. Tehrani, which I really recommend, you can find more information about that at medwellmedical.com. Additionally, our senior lifestyle communities with the Gardens Group, please feel free to reach out to any one of us to answer any follow-up questions that you all might have regarding the presentation or our communities. We are scheduling virtual visits today to help minimize risks involved with COVID-19. So please get in touch with your local community. In addition, Senior Lifestyle does have approximately 180 different communities throughout the United States. So if you're looking for independent living, assisted living, memory care, or even skilled nursing placement, you can find out more about the solutions we could provide to you all at www.seniorlifestyle.com. And we will be providing all of the guests today with little takeaways from today's presentation and tips and tricks on how to better manage dementia. We wish you all well. Stay safe, and thank you so much for joining today.